My faith background, the Church of Jesus Christ of Latter-day Saints, has a strong tradition of supporting the importance of families. That was, back in the 50s and 60s, the families just started to suffer from a lot more stressors. And I thought, well, I have that perspective on it, and I thought that made a lot of sense. I was a volunteer at an elementary school, and we call sixth grade, which is, I think, about age 10 or 12. I was there about 4 or 5 months, and after a month or so, it became obvious that the kids who had trouble in school were those that had the most trouble at home. And it didn't take too long to understand that combination of my own background as well as what I was experiencing with these youngsters led me to family therapy. And that was embedded in another context, which I was working at a General Motors company. So I was coming out of a very blue-collar environment, which I'm proud of. Actually, I learned how to work. I learned how to kind of produce, if that makes sense. So production line process is my academic life. So I got to the end of my bachelor's degree, and I found a counseling psychology program, and I found it at Brigham Young University. And so it was seeing the influence of family support and family problems on the young people in the elementary school. I think that got me started in this direction. In the context of a blue-collar background, I've always been preparing for the next step professionally. And so when I was finishing up graduate school, one of the things I did was interviewed a bunch of people that I could use as referral sources, planning on going into a solo practice. So along the way, I published a couple of articles with my advisor, with his advice, and I knew very little about what was going on in the academic world. But because I had done that, I had an opportunity to go to university as an assistant professor at Texas Tech University. Because I knew the set of problems I wanted to take on were more similar to universities than they were to solo practice. So that's how I ended up starting at Texas Tech University. I was there 4 years, and then was recruited to go back to BYU and be on the faculty there, and I was there for 30 years. I'd spent about 10 years doing studies of divorce prediction and coming out of the behavioral social learning projects that I did related to couples. And I saw that the beginnings of the economic analysis of everything in healthcare. It was very early days, and they were just starting to change the payment systems for healthcare. In the U.S. at the time, and mostly today, providers get paid by the procedure. No matter who you work for, it's the work that you do that you get paid for typically. That began to be being squeezed as the cost of providing healthcare to Americans kept going up. The system started to switch, and it's gone to more of a pay. You buy an insurance manager, a big company would buy the hospital staff, and they would hire them to be employed, and then they work as employees as opposed to private contract. All that was starting, and I knew the group psychotherapy people were being very successful in demonstrating costs. I observed the individual psychotherapy people demonstrating costs, and doing that at all was like a big deal. But I knew there was nobody in family therapy doing it anywhere that I've ever heard of. Simultaneously, a grad student came to me, and his name was David Law, and he worked in a company locally he had his master's in family therapy and was working at a local company in a primary care setting. He came to me and I was his advisor. There was just kind of a confluence of interests. He had access to data. I definitely wanted to find out about the cost to see if we could maintain any kind of presence in the market. It was a little frightening at the time because if the results were really that we showed that we were very expensive, it could be difficult to carry on the field. But we decided to gamble for it. Actually, both of us felt in our heart of hearts that involving families in the system to provide help is got to be beneficial. So we launched projects, and then one project with him led to another with somebody else, or another, and then I ended up doing 20-something years of publications on it. And it's like most things; it just happened to be along the way you grab an opportunity if you can. And our studies were in naturalistic environments. The data I had available were all from people who pay for insurance, pay for treatment. We identified folks who'd had family therapy, couple therapy, who had individual therapy, or combinations of those. In that context, the people who had family therapy by themselves, that was all they had, cost about 20% less to provide them care for any mental health diagnosis. And we studied every one of them. Next was the individual psychotherapy. Was next most effective. The most expensive of all was if you felt like you had to combine both individual and family therapy together. That was expensive, as you could just think it would be. And it seemed to us that meant either the provider didn't really know how to do family therapy. There's some evidence that that's true, or it was kind of a surrogate measure of how difficult the case was. So sometimes when practitioners get stuck working with an individual or family, they bring the other group in. But also it's more profitable to see individuals than it is to see families, because I can see you and then I can see your oldest son. I get paid twice. If I'm individually serving, if I'm doing service as a family, I can see you, your wife, and all your kids for one fee. And so that's kind of complicated, but overall, it would say, I'd be willing to say, without an equivocation, that if people can do family therapy, regardless of the diagnosis, people get better faster with less expense. The industry average for care was about, across all, summing across all the diagnoses. All of them, from adjustment disorder to psychosis disorders, was about 7 sessions, maybe 7 or 8. So very, very cheap, very inexpensive, which helps with the justification of, well, why do you provide this service in healthcare anyway? That discussion's, I think, over. Everybody knows that behavioral health matters. And the U.S. has required now, the federal government has set the standard and requires behavioral health services included in any health service program. That's one group of findings. Another group of findings is I studied the different professions. And we have about, considering all of them, I had like 80 different professions. But the big ones, narrowing down the big ones, psychology, psychiatry, MFT, clinical social work, and nurse practitioners, and studied all those groups, how effective they were in providing different kinds of therapy. As you can imagine, family therapists provide family therapy. It's more effective than anybody else providing family therapy. But it's also true, though, that anybody providing family therapy as a context, not as a model, people get better, and they get better faster. When you compare the professions on other things like do people come back for the same care? We call that recidivism. Family therapist has the least amount of that. The psychologists who are PhDs in America, are PhDs, were the worst at that. They have a lot more dropouts, which I haven't mentioned. Dropouts, people who come to 1 or 2 sessions only. And they also have the highest return to care rate. It's not surprising because in our training in America for psychology, it's a lot of analytical, and not psychoanalytical, but testing, evaluation, kinds of things. And, although they do therapy as well, and do a fine job, their main training is how to do it in testing and like forensic or brain injury, stuff like that. They're really good at that. Family therapists seem to be able to get people in, keep them in, treat them shorter amount of time, and they do better than anybody else. But as a big picture, everybody does pretty well because the completion rate for all the mental health disciplines is about 85%. So people don't come back. We took that as a measure of if they're doing okay, if folks are doing okay. And in this set of studies, by the way, I should mention we had 500,000 patients in this bunch. The only exception to the family therapy is best for whatever mental health condition it is for sex therapy. Sex therapy seems to progress better when you have a combination of couples working together and individual support, whatever is needed there. At the macro level, the systems are identical, which may sound funny, but there's a service that's provided by somebody, and then there's a system by which those people get paid. In North America, the payers of psychotherapy tend to be the employers. The employers buy health insurance coverage for their employees. If they want to attract high-quality employees, they do that. And then one of the benefits, just like being able to go to a dentist, being able to get your eyes examined, going to a hospital, going to your primary care physician, your family doc, and that's paid by that company. So somebody always pays for stuff, no matter what service it is. It costs money. And my understanding of how I translate that to the UK system is the links are much less clear. Funding of the UK healthcare system, well, there's an emerging private system, of course, but the general system is paid for by the national government from sources that are a mystery. Not to you, maybe, but to me. But the sources are a mystery. But I would say, it'd have to be in the tax related to petroleum, diesel. The tax rates are so high for that in the UK. And there's others, and I don't know the details very well. But in the UK system, the providers are all owned by the entity. In this case, it's the government. In the U.S., the healthcare system, providing systems are owned by other entities. There's probably 30% government-owned now. There's probably 60% owned by some big system. So, for example, Cigna is the system I worked with. They have like 60 million subscribers. So anyway, somebody pays for it, and then the providers get paid somehow. So people tell me, in the UK, well, healthcare is free. I say, well, no, it's not. Somebody's paying for it, but it's less clear. The translations, I think, are pretty accurate. If I own / manage healthcare for in this case, 60 million people, I'm going to act a lot like the NHS acts because of just the size of what we're doing. And I think the NHS is going to act a lot like the big healthcare company acts here. The same issues: access, technology, innovation and treatment, supply and demand. All those things are operating in the same way. Although the language is different, it's the same. I think that I think there's always a case that can be made for the outcomes of family therapy. All the experimental studies that have been done now in the U.S., in Germany, and in China. Apparently, there's been a bunch of studies done. Um, and it's not hard to demonstrate scientifically that it's helpful. And it's not that hard to demonstrate. It doesn't cost that much. In those kind of experimental studies, it's not hard to identify. It doesn't take a lot of treatment. If I'm a manager of the NHS, I'm going to say that's nice. So I think we have to make two cases. We have to make the cost case, and then we have to make the quality case, which is the outcomes. And I think most people, if they're sensible and are interested in improving the quality of service to their people, that's the ultimate goal of any of us, I think. Any managers, any providers. How do we help the most people with the least amount of money because we don't have unlimited resources. So if I'm today needing to discuss that with a manager, I'm going to give both sets of cases. I've talked to some of my friends in the UK who are kind of really frightened by what their place is going to be, and if they're going to have jobs and so forth. And so far, most of them still do. The big picture of healthcare is people aren't getting any healthier. Mental health problems are not going away. So I would say be optimistic. And unfortunately, the conditions that we're all experiencing all over the world are not getting better, really. And our services are going to be needed more and more. The context we provide them in, we may have to be creative. We may have to provide, develop for ourselves groups of practitioners that can work together, that can attract contracts, and a whole variety of business models. And the summary of that is be optimistic, be creative, and don't distress because you might lose a position in a system. There's lots and lots of families who need you, and we can get them somehow.